Welcome back, everybody, to episode 2 of Now I Know. I'm Sam Barry, and we're going to be talking about laser vision correction today. So, Sud Koushik, out of Cleveland Eye Clinic right now, of Mizzou fame, chief resident of Mizzou Ophthalmology, and now Cleveland Eye Clinic for refractive surgery. Just a all-around awesome guy, our host for episode 2 of Now I Know. So pumped about it.
I'm very pumped.
So what are we talking about today, Sud? What are we going for?
I think we're going to talk about laser vision correction and refractive surgery as a whole. All the different options that patients have to improve their vision. And then maybe go into a little bit of the nuances of the techniques, the indications, and maybe some cool cases that we can highlight that we've had during our experience of doing these surgeries.
I love it. So just like for episode 1 and for future episodes, we're going to try to do the first third, the first few minutes of the show, 15, 20 minutes of general education should be applicable to everyone. And then the middle third being more aimed towards residents and fellows. And the final third, kind of case-based discussion, more for attendings and other surgeons. But everyone should listen to the whole thing, like and follow as well. All right, so starting us off, where do you want to start in terms of laser vision correction? I could, also start with a brief history of the procedure itself. I find that kind of fascinating.
I love the history. Yeah, I think we should start with that. Why don't you take us off?
Yeah, so as a Tulane guy, as a med student at Tulane, and a lot of family from New Orleans, I have a deep appreciation for the fact that a lot of this research and development of the refractive excimer laser was in New Orleans at LSU with Marguerite McDonald, who's a personal hero of mine. She's incredible. Actually, Sud, you're going to be in ACOS this coming week, and she was there last year, and just hearing her speak about it was fantastic, incredible. Essentially was a history of laser vision correction as the excimer laser was developed, was starting out with monkey testing in terms of getting the laser parameters just right. So initially, actually, they found that they could just etch certain patterns into certain materials with this excimer laser, and from there they realized they could get it so accurate that they thought about using it for improving people's vision. And then starting out that process, obviously you don't want to go straight to eyes that are seeing well. So they started out with monkey eyes, developed that, and at LSU and in New Orleans was where a lot of that research was done. A super interesting story I found was they were kind of relegated to this trailer, so they weren't given really space to develop this. So this trailer was near a trash compactor, and it would turn on and shake the trailer during the testing, during when they were trying to calibrate this laser and do the testing, and they thought it would adversely affect the outcome. But it turns out that when they studied it, it was actually more accurate and better when the trash compactor was going. And the reason for that was the laser spots were more overlapping, there was less step off, it kind of blended it. And so that's why we have, an excimer laser that functions there that we do now, with multiple, very, very small spots, like a, flying spot laser. And that's why it was developed that way. So very cool that the relegation to a bad trailer ended up with a better technology.
That is fascinating. That is so cool to hear about.
The second cool thing that I thought was just amazing about the development was, I had patients that asked me, did somebody just volunteer as the first subject? And kind of yes, but also it was an eye that was not seeing well. So they did what are called blind eye studies. So eyes that were blind from other things like glaucoma or optic atrophy, that had no vision potential. And they were able to measure the curvature of the cornea. And we'll talk about, how laser vision correction works. But basically, they were able to prove that it works and reshapes the cornea the way they want it to without risking anyone's vision. So just a little cool history about laser vision laser vision correction surgery. But maybe you can tell us about how PRK, LASIK, and those sorts of things work and kind of even what they stand for.
Yeah, I think that's a great starting point. So basically, at least when I talk to patients who come in, I just use an umbrella term of laser vision correction, just so that it helps them conceptualize what's going on. And then we can go into the details of things like LASIK, PRK, SMILE. And for LASIK, laser-assisted keratomileusis. Basically, we're reshaping the cornea. Once again, coming like with our etymology, the Greek roots, corneal, and then like reshaping or altering. And so I tell patients that the way it simply works is we create a flap in the cornea, we lift up that flap, and then we actually treat the prescription with a second laser. So we are using two lasers, and then I guess going up a level for medical students and residents who are listening that might find this type of material on their OCAPs or their board prep. One laser, the femtosecond laser, is the first thing we use to create the flap, and that's using photo disruption. And then the second laser, which we're actually using photoablation, is the excimer laser, and that's actually reshaping the cornea to the desired refractive result. So that's LASIK, using those two lasers and how it's done. PRK, photorefractive keratectomy, that procedure, essentially, you are not utilizing a flap. You are removing the anterior-most surface of the cornea and then treating that prescription once again with a laser, and then allowing that cornea to regrow. And that regrowth process can take multiple days, 5 to 7 days on average. And during that time, we do put a bandage, kind of contact lens, to protect the eye and allow it to heal. And so that process is a little bit slower, but also can achieve fantastic results for vision correction. And then the third one that I'll talk about in this brief intro is SMILE, small incision lenticule extraction. And that's a newer technique that uses just one laser, the femtosecond laser, to create a small incision in the cornea and then create the lenticule, which will then be removed by the surgeon, and then you'll have your desired refractive result. So those are kind of, broadly speaking, the laser vision correction procedures that we perform, and kind of the ways in which they vary a little bit. Anything you'd like to add to that, Sam?
That's a great summary. Just thinking about it from a patient perspective, let's say I'm coming to see you, I wear glasses, and that's all the information that you know about me. Could I be a candidate? What does it mean to come in, to get my eyes fixed with lasers? Is it all the same for everybody? Are there certain people that are good candidates and other people that aren't? What's the reason for, seeing you before you can tell me if I am or am not a candidate?
Yeah, that's a great question. Essentially, we just want to make sure everything's safe for the patient. That's our number one priority, is safety. And then, of course, having a wonderful visual result. So I think the things that the surgeon's going to able to look at to determine if you're a good candidate is, number one, your prescription. Are you nearsighted? Are you farsighted? Do you have astigmatism? And then that will help us determine what type of approach we can use. At least in the United States, nearsightedness with astigmatism can be treated with SMILE, but we can't do farsightedness or hyperopia. Whereas LASIK would be able to address nearsightedness, farsightedness with astigmatism. So kind of the whole range there. So that's one way in which kind of the procedure might vary depending on your prescription. Another thing is obviously your corneal thickness. We measure that, and there's a correlation between your prescription and also how much corneal tissue will have to remodel or reshape to give you that desired vision that you want. So your surgeon will be looking at those parameters too, to determine if the structure, the integrity, the safety of that cornea, that clear plastic dome of your eye, will be maintained after doing a laser vision correction procedure. So that will also help them determine what is the best approach for you and whether you're a safe candidate for laser vision correction. There are other things that go into it, but broadly speaking, those are some of the big ones that we look at.
That's perfect. I couldn't have said it better myself. I mean, that's perfect. I actually even have a little eye model conveniently right here for our people that are watching on video. But we're talking about this area right here. That's the cornea that we're talking about, where all this is done. So everything's on the surface or within the corneal stroma. So all right here. Everything inside the eye, where we do other surgeries, cataract surgery, ICL, vitrectomies, all sorts of things. That's all a separate area. So this is all laser vision correction, is really on the surface of the eye, not an intraocular, not inside the eye surgery. And just to re-steer the conversation back to LASIK and PRK and smile. We're going to talk about you and EVO one of these days. We'll do it on a future episode. Yeah. But today's all about me. Today's about LASIK.
Yes.
Today's about smile. Yeah. So going back to indications. So you said nearsightedness, farsightedness, astigmatism can all be addressed with LASIK and PRK. Is that right? So if I'm a patient that's thinking about vision correction, and I look at my prescription, or look at my glasses or contacts, what is that number I'm looking at? Is there a minus in front of it, a plus in front of it? Kind of explain to me. It looks like there's two numbers. Like for me, -4 plus 2, at a certain axis at like 90.
Yeah, so breaking it down,
please.
When you have your prescription out in front of you, the first number denotes your sphere. So it's basically telling you, are you nearsighted or are you farsighted? And so if you're nearsighted, you'll have a minus in front. And if you're farsighted, you'll have a plus in front. The second number is actually denoting your astigmatism and the amount of astigmatism that you have. And you can think of astigmatism, it's everyone wants to think of the eye as like this perfectly round sphere, like a basketball, but really for the vast majority of people, it's not. It's more like a football. There's a steep portion, there's a flat portion, and that's going to bend light differently depending on the way the light hits the flat portion or it hits the steep portion. So that's essentially astigmatism. Those light rays are going to be bent differently and hit a different portion of the eye. And so there's varying degrees of that. So the second number is that astigmatism. The third number, usually a 3-digit number, it just corresponds to the axis of that astigmatism. And so the lens that we use if you're wearing glasses or the contacts has to be positioned in a certain orientation to negate the astigmatism that you have. And so those three numbers together comes up with your prescription. Now, in terms of laser vision correction, I would say the vast majority of patients end up being myopic or nearsighted, so they have a minus up front in that prescription. But we can do hyperopic or farsighted prescriptions as well, those patients who have a plus up front. How do you go into that discussion, Sam, in terms of patient comes in and they're farsighted, they have a hyperopic prescription? I think as refractive surgeons, that's a little bit more of a challenge than the patients who come in who are nearsighted and have the myopic prescription.
Absolutely. I say go see Dr. Sud Koushik in Cleveland. He does a really good job with this laser vision correction thing, and I buy him a plane ticket. I get him a plane ticket, and they come and see you.
I'll just send him right back. No.
Yeah. To answer your question, actually address what you were talking about for a second. So from a patient perspective, that second number, that could be plus or minus, right? I've seen it both ways. So you're right that it denotes the level of cylinder or astigmatism, and then the plus or the minus just is a basically math equation in terms of how we calculate the sphere and the cylinder. So it can be plus or minus. Either way is fine. But like you said, the first number, whether that's plus or minus, tells you if you're farsighted or nearsighted, also known as hyperopia as farsighted or myopia for nearsightedness. And then astigmatism can be in plus or minus cylinder format. So we'll keep talking about this until people, stop falling asleep and start getting tired of us talking about prescriptions. But understanding your prescription is nice, and it's pretty easy when you're younger, let's say below age 45 or so. It's very easy to just take off your glasses and just say, can I see up close? Can I see at near? If you can see at near, you're nearsighted. That's the way I think about it. Farsighted is a bit of a misnomer because farsighted people, yes, if you have a small amount of farsightedness, you can see it far without glasses. But if you have a high enough amount of farsightedness, you can't see distance or near without glasses. And so it's just segueing that into what you asked me about, people that are farsighted or hyperopic that are coming in for vision correction is the minority of people. It is. So maybe we'll concentrate on myopia for a little bit after this. But hyperopia, up to a certain amount, our lasers can treat. So basically there's been FDA trials, like we alluded to earlier, about, what lasers are approved for what amount of hyperopia, and PRK versus LASIK. And that gets kind of into the details of what surgeons are comfortable with and what we recommend and feel like will give a patient a good outcome, right? But in terms of how much hyperopia I'm willing to treat, it also depends on patient age, right? So if somebody is in their early 40s, it's very different than somebody coming, at age 20 or 21 for hyperopia. So we think about different refractive or different procedures based on what level of hyperopia and also the patient's age. So that's a roundabout way of saying I just send them to Cleveland to Dr. Koushik again. How about you? You want to talk a little bit about nearsightedness? So let's talk about me as a patient, maybe, coming in as like a -4, -450 roughly. And then SIL was, negligible, not much. I was wearing normal contact lenses, although, a very brief aside, I wore all kinds of contact lenses. I had a great optometrist when I was a kid, and I think he was well ahead of the curve in terms of myopia control. So I did RGPs, and I also did Ortho-K for a bit. So all those things we can get into the weeds for Tracy and explain what those are on future episodes. But Sam, coming to you, I'm 22, my last year of college. So it was forever ago for me at this point. But last year of college, -4 in one eye, -4.5 in the other. Coming in, I'm saying, I've heard of LASIK. I'd like to, get my vision improved. What do you recommend?
Yeah, I think it's just important to screen for anything that could cause fluctuations in your prescription, and ensure that you've had what we call refractive stability, or that prescription's been very stable over time, and we have a great degree of confidence in being able to hit our target by treating that prescription. So that would be first and foremost. And secondly, of course, rechecking the prescription and comparing it to your glasses prescription, getting imaging of your eye. So for a lot of patients, they don't realize we're doing a lot of measurements, and that's looking at once again, that clear dome windshield, that cornea, and we're looking at the thickness of that, because it really helps us determine based on your prescription. Like for Dr. Barry here, -4, how much tissue are we going to remove, and how will that cornea be left after we're done? So assuming an average thickness of like 550 microns, a -4 prescription is readily treatable with LASIK. And other things we screen for with that imaging is also other kind of medical conditions of the eye, things like keratoconus, which is a condition in which the cornea can kind of bulge forward. It can have weakening, and it can cause a lot of astigmatism, and it needs to be treated. And so we're constantly screening for those other things before we ever make a surgical recommendation. So that's kind of how the discussion would begin very broadly. But to keep it simple for a patient such as yourself with a -4 with an average corneal thickness and no other medical history or no other eye conditions that would preclude doing surgery, you would be a fantastic candidate for LASIK. And I know you had LASIK, right? So
I did,
perfect.
and I'm very happy with it. So hindsight is 2020, and I'm better than 2020, 2015. So great
Perfect.
Recommendation by you to get LASIK. Yeah. Thank you.
Of course, I'm just doing my job.
It's treated me well for 10 years. I absolutely love it. I'm a huge fan. Let's say, somebody comes in and they want all their options presented. So am I a candidate for PRK? Am I a candidate for LASIK? Am I a candidate for SMILE? Am I a candidate for EVO ICL? Where does that kind of fall? And how much of that is, once you establish safety, then how much of it is kind of patient preference, and how do you kind of rank these? If I say, I want all the options, I want you to tell me what you think is best for me.
Yeah. So, in that same scenario, -4 patients such as yourself with normal eye health and anatomy, you fortunately are a candidate for all of the above procedures that we mentioned. So the PRK, LASIK, SMILE, and EVO ICL. Now with EVO ICL, there are a couple additional testing parameters that we do like to get to make sure you're a good fit. And that's essentially because we are putting the implantable collamer lens into your eye, and it has to sit in front of the natural lens that you were born with, that clear natural lens, and behind the iris, the colored portion or pigmented portion of your eye. And so placing that in that location by the surgeon requires a little more imaging software and more calculations that will get very very convoluted very quickly, and
Certainly.
we don't need to go down that road yet. But
Yeah.
but definitely, I think it's an important thing to tell the patient that all these options are available to them, and in terms of ranking them, like you suggested, that's where it becomes a little more tricky, because I think most refractive surgeons don't want patients to feel like one option is suboptimal to the others. I think they're all wonderful procedures, and they all kind of have their pros and cons.
You love
And
you
it's
love
just
all your kids equally. Love all your kids
exactly
just the same. Yeah.
100%. Yeah, I'm not picking, at
No,
least not in
no.
front of them. So I think that is what makes it tricky. I do think if I'm acknowledging my biases with the -4 prescription, I'd be more inclined to offer something like Smile, just especially if they have adequate corneal thickness and otherwise are healthy eyes. Just because I know I can get it done very quickly in one procedure in the OR, in the in-office OR, and they're going to have fantastic recovery. Now, they can also be excellent EVO ICL candidates and also have a wonderful recovery. But I think the conversation, between the two just becomes a little more detailed.
I totally agree. And so much of this, I didn't put you in a fair situation. So much of it is just dictated by patient discussion, and talking with them and educating them and seeing what their priorities are. I mean, let's say you met me and it turns out I'm actually part-time MMA fighter as well.
Yeah.
That would maybe dissuade you from LASIK potentially because of the potential for flap dislocation. Again, it's very rare that would even happen. But I do talk about that for contact sports athletes. The military has done much more PRK than LASIK, certainly. So they think that's, important when it comes to combat readiness. Although, I think the rate of flap complications, even in combat, is exceedingly low. Not to get too far into the weeds. Yeah.
No, I think you brought up an excellent point, because it's something that actually comes up more often than a lot of people think. I just had a patient last Friday I did a consultation with for laser vision correction. And the first thing she told me after we did our kind of brief introductions is that she found us to want to have us perform Smile for her because she does Taekwondo. She does Taekwondo 3 or 4 days a week, and so she was looking up options that didn't create a flap, and so she had seen that we offer Smile, and that had kind of triggered the whole consultation. So I think it does come up, not infrequently.
Just going through that for just a second for everybody out there, PRK, one laser, the excimer laser we talked about the development of, we use that to reshape the front of the cornea, and then afterwards that has to reheal. It has to grow back. So that takes the longest amount of time. So PRK can be a few days, a week of discomfort, a lot of visual variation. It can be ups and downs and kind of just all over the map. And so that is tough to deal with. And the reason that some people prefer, and myself included, chose LASIK is because it's a quicker recovery process, right? But there's not anything free. There's no free lunch in life. So there's risks of flap complications, as rare as those are, from LASIK over PRK. So like anything in life or in surgery, there's pros and cons to each procedure. And then finally, when it comes to Smile, it uses just the one laser, the femtosecond laser, makes a much smaller opening than LASIK does, like you talked about, and then just removes a little lenticule. So in terms of visual recovery, it's kind of on par with LASIK. Doesn't make it as big of a flap, so there's not really the chance of flap complications in that same way. And then in terms of long-term stability, if we're looking at refractive outcomes for all of the above, at least what I've seen recently and in the last 10 or 15 years is at 6 months, they're all pretty equivalent in terms of where your vision is. So the amount of people, the number of people getting 20/20, 20/15 uncorrected vision after each of those is about the same. It's just the path to get there and the risks and benefits of each one vary. And that's what we're here for, is to talk about it and to, talk about it here on the podcast and talk about it in person too for each, we kind of individualize medicine. Eventually we'll get replaced by AI, but right now we're somewhat necessary. And so, unfortunately you have to come see us and talk about your options until AI has gotten to that point where they can decide for you.
That's coming. That's coming fast.
It
right?
is coming. Yeah.
I'm terrified. I don't know what I'm gonna do.
Yeah, I think right now I'm looking on the bright side and thinking it's going to help us with decision making in a way that, at first we understand, and then later on it'll probably know better than us. We won't understand why, but we'll look
That's
at
true.
outcomes of AI chosen plans and human chosen plans, and the AI is going to outperform.
Oh yeah, I've just
Yeah.
watched way too much Terminator, so Skynet's getting ready to turn on. I'm getting worried.
Yeah, yeah. Well, they still need us to hopefully press down on the foot pedal until
true.
AI can do that. So
I love pressing down on the foot pedal. I can do that. Yeah.
that's my favorite part of the day. Yeah.
Yeah. So in terms of going from that natural point where LASIK, PRK, Smile, having these wonderful visual results, especially when you go out about 6 months out, then how do you actually? I mean, we can get into the weeds here with actually
Sure.
deciding between when to use LASIK for a certain patient, and you had touched on that with PRK maybe when you're trying to avoid having a flap or the flap complications. But with things like LASIK, with things like Smile, are there other things that you're looking for in the postoperative period as possible complications, and are things that you're informing the patient about, things that we have to monitor?
Yeah, absolutely. I mean, like I said, there's pros and cons or risks and benefits to every procedure. LASIK, the flap that we create, can move in the immediate post-op period. So it can have these little wrinkles in it that we call striae, micro or macro striae for the residents and fellows out there, and that's something that we have to deal with if it's visually significant pretty quickly in the post-op period. And then longer term, there's things like epithelial ingrowth, and then both short and long term, there's that flap interface. So that means where that anterior or front part meets the back part of the flap, and that interface can have inflammation. In addition to infection, it can just have sterile inflammation, something called DLK, and that's diffuse lamellar keratitis. And that can happen, again, immediately post-operatively. It can also happen far removed from the actual procedure. Usually it's from some sort of trauma. I've seen DLK years later from blunt trauma, just causing inflammation in that interface. I've also seen epithelial ingrowth many, many, many years later that wasn't there originally from a blunt trauma as well. So those are, I don't say all of that in depth to every single patient, obviously, right? But I, try to talk about the pros and cons in a way that it gets the point across and that people can understand. And then I think people do rely on us to tell them, based on what we're seeing on their testing and, what their occupation is, what their hobbies are, what would best suit them. So
Yeah.
I try not to do that in a patronizing way, like you need this done over this, but I try to say, my best opinion for you based on my experience and what I've seen for people like you is this, right? It's either,
Yeah.
LASIK over PRK, or I think you should consider Smile over, LASIK or PRK, or your prescription is, this, so I think EVO is the best for you. So it really, I know it's, kind of dodging the question, but at the same time, everything is customized and individualized. So you could have two identical eyes, but the people there are different, and so the plans for them are different.
Yeah, no, I think that is fantastic. You really drove home the point because more than just numbers on a piece of paper or a prescription that you see in the foreopter, it really is the patient. It really is what is going to suit their lifestyle the best, and what gives them the most satisfaction for years and years down the road. So you can have two eyes, or two patients, I should say, with the same kind of eyes, but vastly different preferences for the type of surgery that you're going to do for them. So I think that's spot on. I did want to randomly mention, because you had brought up the DLK or diffuse lamellar keratitis.
Yeah.
I know as back in residency, I always loved the buzzword "Sands of Sahara."
Oh, yeah.
Did you ever reference that?
Definitely. Yeah.
And then with the new Dune 2 movie coming out recently, I'm ashamed to admit that when I saw the trailer, the first thing I thought of was DLK with all that sand. That's incredibly nerdy, but I figure that is the relationship I have with movies these days. How can I relate it to medicine?
And how you're just consumed by refractive surgery, and
Yeah.
even movies, you're just thinking about how can I relate this to laser vision correction.
Exactly. Yeah. So
Yeah.
I need to get out more and have more of a life. But it's interesting because we talk about these very rare complications like something like DLK, and I did actually have a patient who had Smile. I performed Smile for them, and they did have DLK. And just kind of jumping into this topic for a little bit or a brief moment, for the residents listening in, we can grade DLK, but before we do that, just what is it? Like Sam had mentioned, it's an inflammatory process. It's non-infectious, and we don't really know exactly what causes it. We have different theories and things that we point to. Is it possibly, oil or meibomian gland secretions in the interface, or were there pieces of fiber or debris from the instrumentation that we use that's left in the flap or underneath the flap in LASIK, or inside that pocket where the lenticule was when you did Smile? So all these different things could be actually causing it. And then going into staging real quick, usually it's a pretty quick onset. Within 24 hours, patients can present with DLK, so you can see them on post-op day one. And they'll have these, in stage one, these white, very like punctate, kind of grainy opacities, usually off into the periphery. In stage two, those kind of come and encroach along the visual axis. And then in stage three, it can get pretty significant, and you can even start to see mild kind of development of scarring. And then eventually stage four, you can have corneal melt. It's very severe. And so I'd say the vast majority, when you do see DLK, is just between stage one and stage two. And typically the treatment kind of varies depending on the stage and the severity. So just to talk a little bit about the case I had with Smile, this patient did excellent. Post-op day one, she actually was 20/20 in both her right and left eyes, but the left eye did have some of that stage one DLK out in the periphery. She was not noticing anything, but actually one of the optometrists had seen her immediately and kind of started her on increased steroids. And that's one of the treatments, is to increase the steroids. I saw her back the next day very closely to see how she was doing, and unfortunately it had progressed a little bit where it was involving the center of her vision despite using increased steroids. And
How
so
frequently, just for our like listeners that have some experience with DLK and treating it, it's super, super rare. But people that do enough Smile and LASIK will see it at some point. How frequently were you doing drops on that first day for, was it prednisolone, and how frequently were you doing it?
Yeah, so it was prednisolone, and standard that we use for typical post-op is that first week they're using it 4 times a day, but I had bumped it up to every 2 hours for the prednisolone, so pretty frequent, but still had progression when I saw her back. So at that point, really, you could try going to a stronger steroid. Some people try using other things like Durezol, or even go up on the frequency more, Q1 hour. But I actually had a pretty low threshold to wash it out. So I took her just right back to the minor procedure room, washed it out. I kept the steroids at Q2 hours, and then checked her back again within 3 days. And she was 20/20 still. She was not having any issues, and the infiltrate itself had pretty much disappeared. And checked again a week later, a month later, infiltrate had completely resolved and still maintaining 20/20 vision. So I think it's just it goes to illustrate, even for patients who might be listening, or the average non-medical person who might be listening, you hear about these things, these complications, and they can occur. They're very rare. I think when you look at the literature review for things like DLK in LASIK, it's very broad. I mean, as low as 0.4%, and then some saying a little bit higher than that. And then in Smile, same thing, about that very low rate, 0.3, 0.4%. You have to look at different studies to see what they say, but they're very low. But despite that situation occurring, you can still have a wonderful result with appropriate treatment, good follow-up, good patient compliance. So I think it just goes to highlight that even when we're talking about laser vision correction, and you hear about patients very nervous and scared, which I totally understand, you can still have wonderful results even if a complication were to occur. It just all really depends on good, close follow-up and adherence to the treatment regimen.
I was just going to say that. I was just going to say, like, it's such a rare case to see that. And number one, studying and for us having training and knowing about it is step one. And then step two is, acknowledging that it happened and looking at it and seeing it at the slit lamp. And then what you did great was, embracing it and being like, I'm going to see you every day. I'm going to take care of it. I'm going to do what I think is best, what I would want done for me. And you did all the right things, increasing steroids, washing it out, and she had a great outcome. So it's awesome. Testament to how good of a doctor you are, how good of a surgeon. It's awesome, man.
Testament to being able to see what people have done before me and learn from them.
To kind of end our discussion here, Sud, we're talking about LASIK, PRK, SMILE, and EVO, and laser vision correction, and obviously EVO a little bit different, but refractive options for patients. So we talked about nearsightedness, we talked about farsightedness, we talked about astigmatism. What we didn't talk about is presbyopia. And presbyopia is just a big word for needing reading glasses or bifocals. So unfortunately, father time comes for all of us in our 40s and 50s. And we need, a way to help see up close. What's the reason that, we have relatives and, we have friends, we ourselves, when we get to our late 40s, early 50s, why are we going to need reading glasses? So what's that all about?
Yeah, I mean, so you got to remember how the eye works, as one of our famous mentors.
Oh, this eye? The one I always have with me?
The one that you always have with you in your pocket.
Perfect.
Exactly.
All right. Yeah. You talk about it. I'll point to it. And for our podcast-only audio people, just put down what you're doing. Check out the video. Watch it on YouTube or Spotify. Yeah. But yeah, Dr. Koushik, go ahead and explain to me what presbyopia is.
So we have a crystalline lens in the eye, which Dr. Barry is going to point out. But this lens can actually change its shape, and we call that process accommodation. So when you are trying to focus on something closer to your face, closer to your eyes, that lens actually changes its curvature, and that curvature allows the light to actually continue to hit your retina and remain in focus. Now, as we age, the lens is undergoing normal changes with age. It actually becomes stiffer. That ability for it to change its curvature is reduced. And that essentially is what Dr. Barry was referring to as presbyopia, that change over time. And so for most adults, you'll start to see that in their early 40s. Some can be sooner, some can be later. There is a range. But I would say as a general consensus, you could say early 40s for most people. And now that you're losing that ability to see up close, that's why you start seeing people reach for their readers or get those over-the-counter kind of +1 or +2s to help them when they're looking at the menu at a fine dining restaurant.
I love going to fine dining restaurants. When it comes to LASIK and PRK and EVO, how does that factor into presbyopia or the need for reading glasses? Is that a consideration that we take into account as refractive surgeons?
Yeah, I mean, we definitely take that into account as refractive surgeons. But the thing I would say, just for the lay person, if you're 25 years old and you're considering having laser vision correction, having laser vision correction at that age is not going to change the natural rate at which your lens is undergoing its change and the natural progression for you to then require reading glasses when you're in your, let's say, early 40s. So I think that's an important thing to mention so we dispel any rumors or myths. Having that laser vision correction is not changing what's naturally going to occur due to aging. Now, when you are reaching or you're closer to that age of presbyopia, if you have not yet had laser vision correction and you are now considering that, I think your surgeon will talk to you about different options that are available to you that might, I say, reduce your dependence on glasses or lessen the amount of time you're wearing your readers or delay. So I think that's what's wearing your readers. Ophthalmology is you have these wonderful studies and literature that you can always reference to really learn from and improve your practice.
Yeah, absolutely. And more, it's also, I mean, there's books, there's classic books that we all read and study for. And more for me, I'm finding at this stage, a lot of videos are helpful for techniques, and then also in-person meetings, the one you're going to, ACOS, is great. Yeah. I mean, just leaders in the field talking about kind of the cutting edge. And to get invited to that, man, that's awesome. Congrats to you. And also to be, presenting. That's another honor. That's sweet.
Oh, I'm very excited, but I'm following in your footsteps. You were there last year, right?
Yeah, James and I, Dr. Landreneau. So
Yes.
continuing the Mizzou tradition. It's good to have
Yes.
people representing Mizzou. It's just such a good, training program. I'm super happy. Like people, whenever I get complimented about, surgical skills, it's very nice. And, I try to just tell them the truth, which is that I was just taught very well, had really good mentors. And that came through fellowship and residency both. So.
Yeah. It's been fantastic. I mean, we all just build upon the wonderful, wonderful mentorship that we get throughout residency and fellowship. So we're both so fortunate. So it's been great.
Absolutely. That brings us to the end of episode 2 of Now I Know. Thank you all so much for joining us. See you again next week.